So I'll be speaking on managing diabetic macular edema, top 10 tips. So I think Dr. Gopal Pillai has really made my task easy because the nuts and bolts and all about VEGF and how the pathophysiology and anatomy of this disease has already been dealt with. So I'll just give 10 practical tips which I think are important according to me. Why is this important? Because we know that macular edema can occur at any stage of DR, and it's one of the major causes of vision loss in any case of diabetic retinopathy. So here goes. Tip number 1, look beyond the eye. We must always know that good metabolic control can retard the progression of diabetic retinopathy and even reverse some of the changes, especially macular edema and hard exudates. So look beyond the eye. Don't concentrate only on the eye. Look at the patient holistically. These are the levels which are important, and also ask a history of other medicines like pioglitazone usage, which can also be causing the edema. So this is a very nice slide from the DCCT, which shows a dramatic change in the amount of retinopathy based on the HbA1c ratio. And this also gives us a motivation to tell our patient to control the HbA1c. A group from Chandigarh, Professor Amod Gupta's group, has shown and published in AIOC how lowering the lipids and using statins has helped in reducing the severity of the heart exudates and the subfoveal lipid migration. Number 2, a good clinical exam. This is not a dinosaur which has gone extinct. A good clinical exam is extremely important in every patient with diabetic retinopathy. Tip 3, FFA still has a role. So why do we still need angiography in diabetic macular edema? You need to image the vasculature. It guides the treatment of macular edema, especially in some cases where, of course, we all are going to talk about anti-VEGF, but focal laser still has a role. And subtle neovascularization, which may be missed on clinical exam, is also caught. And I'll just show you one picture, which clinically does, which you see the photo doesn't look so bad. But look at the amount of ischemia, and the patient is not going to get very good vision. So here it's a very good thing to have an angiography. Wide field imaging has helped us, and we're going beyond the macula at factors which can influence the macula and require treatment. Number 4, OCT is indispensable. We can't get away from it. It gives us beautiful in vivo histology like anatomical details, and it's very useful for quantification and treatment of edema and tracking the response. Like to any anti-VEGF therapy we give, to steroid therapy, we have to use the OCT to track that. Tip number 5, don't junk your laser. Non-center involving macular edema, metabolic control first, second should be focal laser. If there's gross thickening, we can have a combination therapy. First anti-VEGF to reduce the edema and then follow it up with a focal laser. This is some typical cases you can see in which the focal laser would do very well. And here's a small animation showing you how it's done. And this is the response to the laser beautifully seen on the OCT. So despite protocol S from the DRCR net, which found that ranibizumab for PDR is non-inferior to PRP, suggesting that this may be a preferred treatment and we can do away with laser, we would still recommend that we still think of laser as a first line in certain patients. And also you must remember, even the conclusions of protocols S says long-term follow-up is required. Tip number 6, and this is the topic of today, all anti-VEGFs are awesome. So I'm not just saying it emotionally that they're awesome. Protocol T compared Avastin, Lucentis and Eylea, and it found that the gains were of course greater for aflibercept than for Avastin, but only for patients with less than 20/50 vision. And 1 year aflibercept was better than ranibizumab, but at 2 years this difference was not identified. So all are really good, and we can use almost any of them for this. Tip number 7, if anti-VEGFs don't work, try Ozurdex. So we have a scientific basis. We have a randomized controlled study of patients who were with persistent macular edema which did not respond to the anti-VEGF therapy doing well with Ozurdex. So this is always in our armamentarium for such patients. Tip 8, so nowadays of course we get eyes which are vitrectomized and they have edema. So how do we handle such patients? We are at a loss to do so. So I'll just, to make it interesting, I'll just show one of my own cases and how she did well. This is 77-year-old lady, first seen in 2011, 6/9 parts vision. FFA looks fairly stable. We said we will observe. She came back after 2 years in 2013. Right eye has bled, so we can't get a OCT, but you can see the left eye OCT with a lot of macular edema. And this right eye, we said conservative management. We had done a B scan. Everything was okay. And the left eye, we gave anti-VEGF. And it didn't do better, so in February, that's after 2 months, the right eye had a vitrectomy. So now you can see both eyes with macular edema. And in this case, because there was a lot of cystoid macular edema, we advised Ozurdex. But patient was not convinced for Ozurdex. She said, I want to observe. Why did we advise Ozurdex in this case? Because there's a lot of evidence to show that there was not much change in thickness with anti-VEGF only, and dexamethasone intravitreal implant for the treatment for macular edema is excellent in vitrectomized eye. So finally, I think since it didn't go down, it didn't budge, we convinced her for Ozurdex. And you can see how nicely the edema has gone down with the steroid implant. So basically, this is just in a nutshell to save time. These are the serial OCTs and what therapy we did. And you can see that later she's quite happy. Both eyes seem to have settled down. And very interesting, the right eye, which was vitrectomized, needed only 3 Ozurdex injections to settle, whereas the left eye, in this 2-year period, required 6 such implants. So now we move to the next tip, tip number 9, don't rush into vitrectomy. So vitrectomy has a definite role in DME associated with VMT. Where there's traction, yes, we must do operation, but it's still very controversial that for non-tractional refractory edema, should we do vitrectomy or not? And the study quoted below from Retina journals found that in diffuse DME with no traction, it produces a short-term improvement in the thickness. Yes, the thickness goes down, but no long-term anatomical or functional improvement. This is one of our patients who in fact did quite well, had a ERM. So we did a vitrectomy, ER removal, and also important, we also combined an anti-VEGF. So we can combine anti-VEGF or Ozurdex on table for such patients. Combination therapy works well and they do well. My last tip, it's not always a retina. So you know, as retina doctors, you may be always inundated with patients from anterior segment people. So this is the story of a very unhappy lady, 624, 618 vision, pseudophakic both eyes. She had good post-op vision, but she said, my vision is gone now, and an urgent retina referral was made. So this was the patient. She was advised better metabolic control and given anti-VEGF. We planned PRP once the edema went down. Nothing happened. She had a lot of edema, so we asked her for steroids. And you can see that edema is persisting. We gave her Ozurdex injection. Still unhappy. You can see her follow-up is very erratic. She's come after 6 months, so we don't even know whether Ozurdex has acted or not. And then after this, she comes after 9 months, and you can see you can hardly get any scan, so the OCT. So something we were missing all along. So the PCO has become so dense that you could hardly image the retina. So we just advised YAG capsulotomy, and you can see how beautifully. And also you can see the traction has gone over the retina in the right eye. So innocuous, so just a small tip that PCO can trouble patients a lot, and we should time the YAG when there's no edema or under the cover of injections. Don't always blame the retina. You can get a very happy patient with this. So I conclude this amalgamation of clinical trial data and common sense is the best bet for our patients. Thank you very much.